All right, everyone, let us start. Thank you so much for joining. Thank you for your kind words of appreciation for the last talk. Today, we come to a different kind of anemia, a different cause for anemia, rather. Uh, Last time, we spoke about what is anemia, what is severe anemia, and conceptually, what could cause a drop in hemoglobin. If you look at the concept, then we understand that fundamentally the uh, RBCs, WBCs, and platelets are manufactured in the bone marrow, and bone marrow is a factory where these three cells are manufactured. For manufacturing these cells, like any factory, our bone marrow requires raw materials, and these raw materials are iron, vitamin B12, and folate mainly. Of course, we also need other micronutrients and proteins, but these three are the main responsible for the production of hemoglobin in RBCs. So, any factory needs raw materials and then it needs the workers. So, the workers will use the raw material and make the end product. The end product in the case of marrow is red cells, white cells, and platelets. What happens to the workers, and when something goes wrong with the workers, what actually happens to the patient, what type of anemia, etc., we will be dealing with in the next session. Today, we are coming to what happens when everything is fine. The nutrition is fine. The factory is fine. It is making enough number of RBCs, WBCs, and platelets. These are coming out in the blood and they are circulating in the arteries and veins and capillaries, trying to do their job. But what happens when not only is the production okay, but what actually is happening is that the rate of usage is very high. What that means is if you look at red blood cells, normal red blood cells, after they are manufactured from the marrow, they come out in the blood. They typically live for about 120 days. That's, 4 months. Of course, there's a range, and if you actually measure it, it varies somewhere between maybe 70 to about 150 or so, or even something different. But a good rule of thumb is to remember that a normal red blood cell lifespan is 120 days. Now, the production of the marrow is based on this normal lifestyle. So the marrow makes X number of RBCs per day, for example. They go out in the blood. They're supposed to live there and do their job in the blood vessels, in the pipes through which the blood flows for 120 days. And after 120 days, on an average, whatever was manufactured yesterday, 120 days later, they should die. However, if the death is occurring faster, what that means is if younger RBCs are dying, even before they become, 120-day old RBC, if RBCs are dying younger, then that is called as excessive consumption. And this again is not a rare problem in your practice. Every now and then you will see patients in whom the nutrition is fine, the RBC production is fine, but they are just getting used up. So typically, what happens when RBCs get used up, and we will look at that. But this is the kind of a table which you're seeing right now on your screen that you have seen throughout your education. So from physiology to pathology, you've seen that a breakdown of RBCs, that is hemolysis, right? RBC being a balloon, and what will break this balloon? That is hemolysis. There can be problems that a patient is born with, that is inherited congenital issues. There may be problems that are acquired after birth, later in life, because of which RBCs are breaking down. Yeah, these problems can be with the RBC itself. Now, if we look at the structure of a red blood cell, it is nothing but a balloon, and the cell membrane is there, which is, like the balloon. And inside, instead of the water that a balloon has, there is cytoplasm, and the cytoplasm has nothing but hemoglobin in it. So, essentially, a red blood cell is a balloon which carries hemoglobin, correct? So there could be a problem in the balloon itself. There could be a problem in the cell membrane. There could be a problem in the cytoplasm. So there are enzymes in the cytoplasm, metabolic enzymes such as G6PD, pyruvate kinase. If these enzymes are congenitally defective, deficient, then that can lead to excess and early breakage, death of the red cells. There could be problems outside the RBCs. So it's very much possible that the red blood cell by itself is healthy, and but from outside, either the blood vessel, through which it is going, or there are antibodies in the plasma which are sticking to the red cells and breaking them, correct? Or there may be toxins in the blood which are damaging the RBC cell membrane, or there may be malaria inside the RBC. And as the malaria parasite grows, it kills the RBC and it gets released in the blood. So the problems which can potentially cause hemolysis may be with the RBC itself, the cell membrane, the cytoplasm, the hemoglobin, or it may be external, they may be inherited, or they may be acquired. However, if you look at this table a bit closely, you will notice that the inherited problems, the congenital problems, are usually of the red cell itself. Very few congenital problems outside the red cell will actually kill the RBC, right? And one of them is the hemolytic uremic syndrome, where there are fibers laid down in the blood vessel and the RBCs get entangled in the fibers and they break. There is hemolysis. So, except a rare problem like familial HUS, hemolytic uremic syndrome, most of the inherited causes of hemolysis are actually problems with the RBC itself. Now, the way nature has designed every cell is so beautiful. The cell membrane actually has a skeleton. There is a cytoskeleton. And, in a tent, how you have these poles and ropes which are holding a tent together. Similarly, there are these ropes, cytoskeleton structure which hold the cell membrane. So any mutation in the genes which create the proteins of the cytoskeleton can lead to damage in the shape of the RBCs. And when the shape is damaged, the RBC, instead of a donut shape, might actually become spherical. It might become elliptical. And when it is not donut shaped, it cannot go through the small capillaries. There is a very important reason why the RBC is donut shape, because this donut shape allows the RBC to fold. So when it is going through very thin capillaries, it can actually fold and go through. It does not get blocked and thus break. Hence, any problem with the cytoskeleton of the RBC cell membrane can damage the shape, and thus the RBCs will break down in smaller, tiny microscopic vessels. Inside the RBCs, the hemoglobin molecule itself, hemoglobin is made of two alpha and two beta chains. That is the quaternary structure of the hemoglobin protein. But if this balance is not maintained, for example, in beta thalassemia, the beta chains are not manufactured. Congenital problem. There is a genetic mutation. So if beta chains are not created, there are only alpha chains. These alpha chains are unstable. They are unstable and they will lead to the breakage of the RBCs. Similarly, in sickle cell disease, the hemoglobin gene has a mutation, and as a result of this mutation, what happens is, the hemoglobin gene will not remain soft. The hemoglobin protein will not remain soft and flexible. It will not. Whenever there is deoxygenation, the oxygen goes away from hemoglobin, the hemoglobin protein will crystallize, it will make spicules, and I'll show you a picture later on. Nevertheless, what I'm trying to say is most of the genetic causes are problems with the red cell itself, and most of the acquired causes of hemolysis are external to the red cell. There is something happening in the body. Either there are antibodies which are getting attached to the RBCs, or there are toxins which are damaging the cell membrane. You know, any of these can damage the RBC from outside. Now, this is the last that we'll be looking at this kind of a classification, because, like I had said yesterday, our entire talk is going to be practical. We are not going to get into the etiology and what are the mutations and what are the proteins. No, this is a pure practical talk. So it will help you understand, what actually happens. So, logically thinking, let us see what happens when an RBC breaks down. I told you multiple times that RBCs are nothing but balloons filled of hemoglobin, and that's how they look. They're donut shaped. Like I said, there is a donut shape because so that it can fold and go through thin capillaries. Right? Isn't that beautiful? That's a scanning electron micrograph of a red blood cell. However, what happens in hemolysis is the cell membrane breaks, and thus the hemoglobin comes out in the plasma. And when it comes out of the plasma, it will go into the liver and it will metabolize, right? Which means that there is less hemoglobin in the circulating red cells because the red cells are dying. The hemoglobin protein comes out in the plasma. The blood takes this plasma hemoglobin to the liver, and the liver is nothing but a giant chemical factory. The job of the liver, the job of the liver is to break down proteins. That's what it does. So similarly, it will metabolize or break down hemoglobin into bilirubin, indirect hyperbilirubin, and then indirect will become direct. But you can think logically that if red cells are breaking, hemoglobin is coming out, then the high plasma hemoglobin will get converted by the liver into indirect bilirubin, right? So when you do a blood test, you will get high indirect bilirubin. However, we need to remember that high indirect bilirubin can also happen because of a problem in the liver itself. What that means is some of us are born with mutations in the gene, in the protein, the enzyme which is required to convert bilirubin from indirect to direct, right? The enzyme which is required to convert indirect to direct. So if that enzyme gene is mutated, this metabolism cannot happen. If the metabolism cannot happen, indirect bilirubin will go up, even if there is no hemolysis. So what that means is the normal, 120-day lifespan of RBCs. The RBCs are breaking at a normal rate. You're not seeing increased breakage. But even that normal level of hemoglobin coming to the liver, getting converted into indirect, further, the liver is not able to change it to direct. This is called as Gilbert syndrome. So in Gilbert syndrome, you will get indirect hyperbilirubinemia, but that's not because of hemolysis. That's just because the liver is unable to convert indirect to direct, right? So that's an important differential diagnosis for hemolysis. And again, we will come to that. This hemoglobin which escapes in the plasma, like I said, the liver converts it into indirect and also a little bit of direct, but the rest of the liver function test is normal. This is important, right? So your enzymes, SGOT, SGPT, the protein, albumin level, alkaline phosphatase, GGT, all of that has to be normal for us to start suspecting hemolysis. The free hemoglobin also binds to another protein called haptoglobin. Now, this haptoglobin is a carrier molecule. Okay, it's a carrier protein that is just floating around in the blood. And anytime a red cell breaks, the hemoglobin comes out. This haptoglobin binds to hemoglobin so that it can navigate it properly to the liver. What that also means is if you have too much RBC breakage, if you have too much hemoglobin coming out in the plasma, It will bind to the haptoglobin and the haptoglobin levels will go down. So, if we look at this, we realize that with hemolysis, we're going to see an increase in indirect bilirubin and a decrease in serum haptoglobin level, right? Along with the hemoglobin, the cytoplasm of practically every cell has multiple enzymes. And one of the enzymes is lactate dehydrogenase, LDH. LDH. So when any cell breaks, the LDH in the cytoplasm comes out and becomes serum LDH. So in hemolysis, when a lot of RBCs break, lot of LDH which is inside the RBC cytoplasm leaks out and increases the serum LDH. And finally, to protect the body of the patient, the factory that is a marrow will start increasing the production. So whenever you have excessive breakage of RBCs, whenever you have hemolysis, you see all of these changes. You see increased indirect bilirubin, decreased haptoglobin because it's used up to carry the HB, high LDH, and the marrow, decides, okay, boss, the RBCs are breaking. I have to increase production. Otherwise, how will this person live? And not only does it increase production, it now has to push the marrow has to push younger RBCs into the circulation, into the blood. Okay, just a minute. So the marrow ends up putting younger RBCs into the circulation. Now, you all know that RBCs don't have a nucleus, right? Almost all other cells of the body have a nucleus. So what happens to this nucleus? Inside the bone marrow, as the erythroid precursors mature and they make more RBCs, right? RBC is the last stage of maturity, last stage. Before RBC, you have reticulocytes. They are young RBCs, they still have some RNA in the cytoplasm. They don't have DNA, they have RNA in the cytoplasm. So before RBC, you have reticulocytes. And before reticulocytes, you have nucleated RBCs. Nucleated. That means it does have a tiny nucleus. And when the nucleated RBC squeezes out of the marrow and enters the blood, the nucleus stays back in the marrow. Okay? So when the nucleated RBC squeezes out of the marrow and enters a capillary, the nucleus stays back. So normally, we don't see nucleated RBCs in the blood. You may see some reticulocytes which still have RNA, but no DNA, no nucleated. But what happens in hemolysis, because the marrow is now working very hard to keep up and make new RBCs, it even pushes out some immature RBCs. So you start seeing nucleated RBCs in the peripheral blood circulation. Okay? Imagine this is like a war zone where a lot of soldiers are dying, right? Hemolysis, a lot of soldiers are dying. So after some time, you will see younger and younger soldiers coming into the war, correct? We often see this for wars which are going on for years and decades. Small children living in that country are given guns and said, all right, you go and you fight. Similarly, younger RBCs come out in the form of reticulocytes. So you have increased retic percentage and you have nucleated RBCs in the blood, which you normally never see. So you see, this is a nucleated RBC. And we only see this in the marrow. So when we do a marrow exam and we look under the microscope, we see these normally. But when you start seeing these in the blood, that means the marrow is pushing out immature RBCs. Now, this is the concept of the pathophysiology of hemolytic anemia. In your practice, you have often suspected this condition. You have often suspected that, hey, maybe this patient does not have nutritional anemia. Maybe the RBCs are breaking down. Okay. It's not nutritional. It's not hemorrhage. It's not hemorrhage. You see, hemorrhage means RBCs go out of the body. Okay. Hemorrhage means RBCs go out of the body. Whereas hemolysis means RBCs break inside the body. So you suspect that no, no, somebody has hemolytic anemia, one of your patients. So when do you suspect? Of course, there has to be anemia. And I'll tell you why I'm coming to this. Okay. Second, you start seeing immature RBCs. You see that the reticulocyte count is high. On the peripheral smear, your pathologist start telling the RBCs don't look normal. They're target cells. Maybe this is a thalassemia. Maybe this is a hemoglobinopathy, right? You see, that this is a scanning electron micrograph of a patient. You see, normally RBCs should have plenty of cytoplasm and a tiny central pallor. Whereas here you see these RBCs, the central pallor is so large because they have very less hemoglobin. They have very less hemoglobin. And then this is a target cell, how it looks in an electron microscope. So a pathology friend calls you and says or writes in the report, target cells plus plus. So you start thinking, is this thalassemia that I'm dealing with? Or they say, I'm seeing the RBCs are getting clumped. They're getting clumped, they're getting attached, they're sticky, they're getting attached to each other. And this is how clumped agglutinated RBCs look under the microscope. You see, they should look single. Instead of being single, they're sticking to each other. Why are they sticking to each other? Because there are antibodies between them. This is an immune reaction. There are antibodies in the plasma. The antibodies are sticking to the RBC membrane from outside, and then two RBCs stick to each other, and two more stick to them, and three, four more stick to them, and they form a clump. Okay? So your pathologist tells you RBC clumps or agglutination seen. So if the RBCs are sticking to each other because of antibodies, maybe the antibodies are also breaking them, right? Immune hemolytic anemia. Maybe the antibodies are breaking them. So maybe my patient has hemolytic anemia. Or the pathologist just writes sickle cell seen. They're telling you straightforward that, this RBC, which is supposed to be donut shaped, is actually weird. It's like a sickle. It's like a sickle used to cut crops by a farmer, right? So you see in this RBC, the hemoglobin protein, which has to be soft, has crystallized. And because it has crystallized, it has stretched the RBC. And now, when this RBC goes through a tiny capillary, it's going to break, right? So there may be something on the peripheral smear that will make you suspect that, hey, maybe my patient has hemolytic anemia, or you're seeing the end result of hemolysis. So high indirect bilirubin, the patient also has jaundice along with anemia, or sometimes, and actually this is quite often this is missed. Last year itself, I have seen two patients. One, a young boy of about, I think, 12, 13, and another was a gentleman of in his 20s, late 20s. And both of these patients had gallstones, right? Very early, young age gallstones. And, the surgeon did a cholecystectomy, removed the gallstones. But nobody ever asked, why does such a young person have gallstones? You know, and in fact, when I went back and looked at the ultrasound, which was done before cholecystectomy, these patients also had splenomegaly. Why would somebody with just normal gallstones have splenomegaly, and why would it happen so young? So sometimes patients just present with gallstones, and for 5, 10 years, nobody realizes that the gallstones were because of hemoglobin, right? And high hemoglobin and the bilirubin, which then condensed in the gallbladder. Of course, the hemoglobin can also be so much that not only does it go into the liver and become indirect hyperbilirubin, but the hemoglobin can also come out through the kidneys as cola-colored urine. And there is a particular condition called paroxysmal nocturnal hemoglobinuria. Paroxysmal. That means the RBCs, yeah, they are hemolyzing every day. Once the condition develops, it's an acquired condition. The RBCs are breaking down, but then sometimes, due to some trigger, a lot of RBCs will break at once. So there'll be a lot of plasma hemoglobin, and some of it will come out as cola-colored urine. So the patient, over repeated cycles, may notice and tell you that, doctor, every time my hemoglobin drops, my urine becomes dark. My urine becomes dark. Some people will say, I pass blood in the urine. But then when you ask, so is your urine red? They say, no, no, it is like brown. So they mistake cola colored hemoglobin urea to, hematuria. Hematuria means blood in the urine. Hemoglobin urea means brown cola colored hemoglobin in the urine, which comes out when there is sudden hemolysis, right? Of course, patients who have a lot of hemolysis, the significant hemolysis, the HB will drop to the extent that they need transfusions and multiple transfusions, recurrent transfusions. Not only that, frequent transfusions, frequent. Now, let me explain this to you. In the last talk, I told you that in many patients with iron deficiency and vitamin B12 deficiency, what we see is their hemoglobin drops. Somebody gives them one blood transfusion and one packet of blood, packet of packed RBCs contains 1 year supply of iron and B12. 1 year supply. So with that blood, not only does the hemoglobin go up, but the body gets a lot of vitamin B12 and iron. Correct? And then the stores get packed up for a year. And then after 1 year, again the iron and B12 level goes down. And after 2 years, the hemoglobin goes down. And after 3, 4 years, the patient again comes with severe anemia. But what that means is patients with chronic iron deficiency, vitamin B12 deficiency will require blood transfusion once in 3 to 4 years. Once in 3 to 4 years. So when nutrition is less, blood transfusion is required once in 3 to 4 years. Okay. What happens in bone marrow failure? What happens in patients with aplastic anemia? Okay. Or what happens in those patients in whom we have given chemotherapy for leukemia and the chemo has killed the bad cancer cells, but it also kills the normal bone marrow. So the bone marrow becomes empty, it becomes aplastic, right? Aplastic anemia can happen by itself as an autoimmune problem, or it can happen because of chemo. So when the marrow is empty, when the factory does not have any workers, that is called as aplastic anemia. So what happens in aplastic anemia is patients require blood transfusion once a week, right? So even if the bone marrow is not working, you give a packet of blood, generally hemoglobin will be okay for a week. Again, next week you have to give another packet. What happens in hemolysis is the hemoglobin will drop in 1 day or 2 day or 3 days. Okay. What that means is even your transfused blood is getting broken. This means that even your transfused blood is getting broken. So in hemolysis, not only will the patient require multiple transfusions or recurrent transfusions, but the hemoglobin does not sustain for about a week that we expect it to. It will drop. That means the transfused blood is also getting broken. Or you've given blood and the hemoglobin does not rise. What that means is you're given blood, and by the time 4 6 hours later, your nurse goes to check a CBC. By then, all the transfused blood is destroyed. So you may not see a proper increment. You may not see a proper rise in hemoglobin after transfusion. Now, one of the things that I'm sure all of you have encountered at least once is there is a particular type of hemolytic anemia where when you try to give blood, you send the patient's blood for grouping and cross matching to a blood bank. Correct? For any transfusion, you have to send the patient's blood for grouping and cross matching. What the blood bank will do is it will do the blood group. So it will tell you, okay, this patient's group is A positive or B negative or whatever. Then it will take the blood bank is supposed to have a stock of red cells, and they will say, okay, this patient has B positive. So let me take two B positive units that have been donated. I have the bag and I will cross match. I will cross match the patient's blood with the sample from the donated bag. And if the cross match is compatible, if there is no clotting agglutination, if it is compatible, then the blood bank will say, all right, you can take this donor's blood and transfuse. Okay. But sometimes the blood bank will call you and say, hey, I'm not getting a compatible unit. I have cross match 3, 4, 5 units. Everything is coming, 2 plus, 3 plus, 4 plus. Incompatible. Incompatible. That is also one type of hemolysis. What is happening is the patient's blood has antibodies, the plasma has antibodies. These antibodies are attaching to the red cells like this. They clump together, like this. Autoimmune hemolytic anemia. And the patient's own auto antibodies against RBCs are making them clumped and breaking the RBCs, hemolysis. So, this is autoimmune breakage of RBCs. And when you try to cross match these antibodies, IgG, these antibodies in the patient's plasma will also attack the donor RBCs. In the slide, when they are doing cross matching, they will attack the donor RBCs. The donor RBCs will also stick to each other and break. Okay, when they stick to each other means there is agglutination. When there is agglutination, it means the blood is not compatible. So the blood bank will call you, buddy, I can't give you any blood. I'm not getting any compatible unit. So these are the clinical scenarios: anemia, high retic count, or NRBCs on the peripheral smear, target cells, that is abnormal cells, target cells, clumped, sickle, indirect hyperbilirubinemia, okay, leading to jaundice, gallstones, hemoglobinuria, leading to cola colored dark urine, patient requiring transfusions which are recurrent and frequent, hemoglobin is not rising, okay, and the blood bank sometimes tells you, I'm not able to get a acceptable cross matched unit, right? These are the scenarios where you start thinking that no, no, maybe this patient's anemia is not because of iron B12, it's not because of a marrow problem. Basically, the RBCs are breaking. So now let us see what is a practical approach to hemolysis. Okay, and our approach is going to be fivefold. We're going to cover this topic with 5 points. These 5 points will help you manage your patients, or at least try to make sense of what is happening to your patient. Okay. So, first, you have to ask yourself, is it really hemolysis? Sure, there is indirect hyperbilirubinemia, but is there anemia? When we talk of hemolysis, basically HB has to drop, right? If the HB is not dropping, if there's only indirect hyperbilirubinemia, that may be Gilbert syndrome, that may be a liver problem, may not be a blood problem. Okay, so to ask yourself, is it really hemolysis? That's the first thing. Second, is it megaloblastic anemia? Now, why am I putting this here? Why am I putting this here? You will see. I'll explain it to you. Third, okay, now I'm sure it is hemolysis, but is it immune? Is it autoimmune? That is the first test that you will do. Whenever you suspect hemolysis because of the, pathophysiology that I mentioned some time ago, first thing that you will do is you will do a direct Coombs test to look for autoimmune hemolytic anemia, AIHA, autoimmune hemolytic anemia. Okay, that's the first test whenever you think of hemolysis. Now, if that is positive, you will call it AIHA. If it is negative, the DCT, direct Coombs test, is negative, then the approach for children is different and the approach for adults is different. Okay. So we'll be using these 5 parameters to work up our patients. So, what do we mean by, is it really hemolysis? If the patient has normal hemoglobin, for example, every now and then I get a consult. Somebody says, my patient has a high bilirubin, and I have looked at everything. I've looked at viruses, and I have done autoimmune hepatitis markers, but hemoglobin is high. Sorry, bilirubin, indirect bilirubin is high. Maybe he has hemolysis. And then I check the hemoglobin is 15.5. If the high indirect bilirubin is because of RBCs breaking down, the HB has to reduce. HB has to reduce. If the HB is normal or high, then the high indirect bilirubin is not hemolysis, it's a liver problem, right? So, how will you know? You check haptoglobin. Very simple. See, LDH can go up due to many causes, bilirubin can go up due to many causes, but haptoglobin decreasing is only because of hemolysis. Okay. So if you want to be sure, is there really hemolysis going on? Do a serum haptoglobin. If the haptoglobin is normal, probably no major hemolysis. If the haptoglobin is down, yes, there is hemolysis, and the free hemoglobin is binding to the haptoglobin, bringing down the blood level. So serum haptoglobin will help you understand, is there genuine hemolysis or not? Okay. And if there is not, do a Gilbert mutation analysis. This is the only way you can prove that high indirect bilirubin is because of Gilbert. You have to do a mutation analysis, nothing else. Now, suppose your patient genuinely has low hemoglobin with high indirect bilirubin. What are you going to do? You will not believe how many times patients with megaloblastic anemia get referred to me as hemolytic anemia. Okay. And if you remember from the last class, what happens in B12 and folate deficiency? Do you remember? What happens in the bone marrow? As the bone marrow is making new RBCs, lots of RBCs, if you don't have B12 and folate, right? The cell size will grow on increasing, but the DNA inside the cells in the bone marrow cannot mature. The nucleus, the DNA cannot mature. So, as a result, the cells in the bone marrow cannot mature and come out in the blood. They will break in the bone marrow itself. There will be hemolysis inside the bone marrow, intramedullary hemolysis. Okay, it is a type of hemolysis, but then not only RBCs, but even WBC and platelet precursors are dying in the bone marrow because vitamins are not there, DNA cannot mature, the cells keep on dying inside the bone marrow. How will you know whether hemolysis is due to megaloblastic anemia? Well, megalo, large, mean corpuscular volume is high. Because the cells are dying in the marrow, the LDH is high. Sometimes it can be high in thousands, right? And then you see on the peripheral smear typical multi-lobed neutrophils, polymorphonuclear neutrophils. If these things are there, and along with the low hemoglobin, even the WBC and platelets have started coming down. Maybe that indirect hyperbilirubinemia is because of intramedullary hemolysis, which is not actually a hemolytic anemia. It is a B12 or a folate deficiency, right? So what will you do? You'll do serum B12 level, folate level, ferritin level. That's it. You've gotten the diagnosis. Okay. So first, before you start evaluating a patient as hemolytic anemia, you will check the HB. If required, you will do a haptoglobin and you will determine whether there is hemolysis or not. If there is no hemolysis, you can comfortably tell your friend that, hey, this is a Gilbert mutation, probably. That's why bilirubin is high. This is not a blood problem, this is a liver problem. Also, you will ensure that it is not really megaloblastic anemia because it's so common in our country, right? By doing these things. Now, suppose you've ensured that yes, the patient in front of me certainly has hemolysis. Certainly, haptoglobin is low, retic is high, blah blah blah. Like I said, your next step, your next step is going to be doing the direct Coombs test. Okay, so certainly there has to be anemia. You have the other features of hemolysis that I showed you in the previous slides. Now you are checking that yes, retic is high, LDH is high, you've done a liver function test, you ensure that yes, there is definitely hemolysis going on. The first test that you will do is direct Coombs test. Okay. Now, what is this direct Coombs test? It's a very fascinating test. This is a simple example of that. So these are our red blood cells and they are floating freely in the blood. Normally single red cells are floating in the blood, carrying oxygen around the body, carrying carbon dioxide back. But sometimes what happens is, like other autoimmune problems, the body's immunity, the body's police force, immunity is our police force. So the body's police force, instead of attacking the criminal, will attack the good citizens, right? Autoimmunity. So the body's immunity, gets triggered by an infection and then after some time goes crazy and starts attacking its own cells. That's an autoimmune problem. Now, when these attack the RBCs break. How do they break? Autoimmunity means antibodies are made, autoantibodies, and these antibodies will stick to the RBC surface. You see, they're sticking to the RBC surface, and then the RBCs will stick to each other and they form a clump and then they can break. So, this is the direct Coombs test. There is nothing great in it. But the direct Coombs test, every lab will tell you is it positive or negative, right? Every lab will tell you whether it is positive or negative. And if they say positive, you will start thinking, yeah, yeah, DCT positive, this must be autoimmune hemolytic anemia. No, my friend, you have to check at the strength of positivity. Okay, you have to understand whether the positive is 1 plus 2 plus. Okay, if it is only 1 plus or 2 plus, it is clinically insignificant. Of course, there are rare autoimmune hemolytic anemias where the DCT can be negative. Okay, but we are talking of common problems in your practice. So, somebody tells you DCT is positive doesn't mean anything. You do ask them, is it 1 plus, 2 plus, 3 plus, or 4 plus? And if they say it is only 1 plus, 2 plus, it may be not significant, right? If it is 3 plus, 4 plus, however, usually is significant, you know and this is what is the meaning of 3 plus 4 plus. See, this is a nice button of RBCs. This is called as a button of RBCs. This is 4 plus. 4 plus means the RBCs are sticking to each other so nicely that when you centrifuge you get a good button. Okay, so 3 plus 4 plus means significant autoimmunity is present. This must be AIHA, autoimmune hemolytic anemia. Now, like I said before, this is also the condition where your blood bank will call and say, I am not getting a compatible unit because the immunoglobulins, the antibodies in the patient's plasma will also stick to the donor RBCs. And when they are doing the cross match looking under the microscope, the donor RBCs will clump. So it will look like it is incompatible. It is incompatible. So how are you going to give this patient blood? If the cross matching is not compatible, how are you going to do this? Because every unit that you test for is going to cause clumping. There are antibodies in the patient's plasma, man. What are you going to do? So here you have to transfuse whichever unit is least incompatible. Every unit is incompatible. Okay, the cross match should normally be 0, but now every unit is 3 plus 4 plus incompatible. So you say, okay, whatever in this 4 5, whichever is the least incompatible. So 2 plus 3 plus, you give me that, I'll give it to my patient because the hemoglobin is so low, I have to transfuse. Even if the transfused RBCs are going to be broken down, but I have to give, right, if the hemoglobin is very low, right? And that is why in this condition, in autoimmune hemolytic anemia, we maintain a cutoff of only 5 grams. In all other problems, if the hemoglobin drops below 8, we transfuse. But in AIHA and nutritional anemias, iron B12, we wait till the hemoglobin goes below 5. Why? Because you can never increase the hemoglobin to 7, 8. Everything, the cross match is so difficult. Where will you get least incompatible unit, right? So this is a peculiar problem and we'll come to this in some time. Now, you have ensured there is hemolysis. You have ensured this is non-megaloblastic anemia. You have done a direct Coombs test. Direct Coombs test is negative. DCT is negative. Okay. Now, what is the cause of hemolysis? Like I said, it's different in children, different in adults. In children, once you have done DCT is negative, you're also going to look at the peripheral smear. Okay. And you're going to see if there are target cells, sickle cells, or bite cells. Bite cells. Okay, see, these are bite cells. You see what has happened here is this is a patient with, this is an electron micrograph of RBCs of a patient with G6PD deficiency. In the donut shaped RBC cytoplasm, because G6PD is deficient, okay, whenever you give a drug that requires G6PD enzyme, that drug will cause problems in the cytoplasm. It will cause problems in the cytoplasm. And there'll be some clumps in the cytoplasm. When the clumps happen, the macrophages in the body will eat away the clumps, and along with that, will also eat away some of the RBC cell membrane. It will try to clean up the RBC. So these are called bite cells. If you're seeing bite cells, then there may be an enzyme problem, RBC metabolism problem. Okay. You'll also look at the other features of hemolysis. So the bone marrow, will compensate to increase blood production, but it can only do something to a limit. It is inside a bone. The bone marrow cannot expand. It is inside a bone. So what will happen is some of the hematopoiesis, some of the production of RBCs will be shifted to the liver and spleen. And the liver and spleen will start becoming factories for making RBC. So you look at the peripheral smear, you will look at the spleen. Now, if these are there, then probably this is an inherited problem. You remember I told you commonest problems of hemolysis in children are inherited. Okay? So if the hemoglobin is low, you're seeing hemolysis and there is spleen, then you're probably dealing with a hemoglobinopathy. You're either dealing with a thalassemia, okay, HBE disease, E beta thalassemia, varieties of hemoglobinopathies, or something is wrong with the cell membrane. So, hereditary spherocytosis, correct? So, some inherited problem in the cell membrane, or the hemoglobin or the enzyme in children in DCT negative. It's not autoimmune, right? So, how do you diagnose? Well, if you are looking for thalassemia, if you're looking for thalassemia where there is a mutation in the hemoglobin gene, correct? There is a mutation in the hemoglobin gene, which means my thalassemia patient's hemoglobin protein and a normal hemoglobin protein, they are different. And I can do electrophoresis of the blood and find out what kind of hemoglobin is there. The electrophoresis will tell me, yes, this patient has thalassemia or this patient has sickle or HBE beta thalassemia. However, However, the sample for electrophoresis should be sent before the first transfusion. This is especially important for pediatricians. Especially important. When a child is brought to you at 3 months, 6 months, 1 year, 2 years, 3 years of age with severe anemia, you and you have to give blood transfusion, you tell your resident, wait, keep one sample before starting the transfusion and send it for HB electrophoresis. Because once the transfusion is given, you have the transfused RBCs mixed with the patient RBCs. Now, suppose your patient pre-transfusion had a hemoglobin of 5 grams. Suppose your patient had a hemoglobin of 5 grams, okay? And you have given 2 3 units of blood, right? So now that 5 gram has become 10 grams, which means 50% of the hemoglobin floating around in the blood is the donor hemoglobin. So you're not going to get the right diagnosis by electrophoresis once the transfusion is done. Quite often, what happens in hemoglobinopathy patients is they need transfusion every month, otherwise, they will die. They'll die of anemia. So, you can't wait for the transfused RBCs to die. Normally, what we do is by chance a transfusion has been given and you forgot to take a electrophoresis sample, HB electrophoresis sample, that's fine. We wait for 120 days, 120 days. You remember lifespan of RBCs. That means at least 3.5 months we wait. Okay. And after that, we take the sample for electrophoresis. But in thalassemia, especially thalassemia major, the child is going to require transfusion every month. You can't wait for 3 months without transfusion. The baby will die. So then how do you get a diagnosis? You do mutation analysis. You do mutation analysis. How does mutation analysis help? You see, you're transfusing PRBCs, correct? And donor PRBCs don't have a nucleus. Yeah. So the donor nucleus DNA does not enter the patient, only hemoglobin is entering. You may then say, but there'll be some WBCs. WBCs, donor WBCs will have DNA. Yeah, but they're very few. Very few, right? So even after transfusion, when you take the patient's sample, the DNA of the patient's WBC is tested for mutation analysis. So if you have given a recent transfusion and you want to diagnose a hemoglobinopathy, you can always send hemoglobin mutation analysis even after transfusion. But you can't send electrophoresis. Okay? If this is positive, it's a thalassemia syndrome. If it's negative, well, maybe it's not a problem with hemoglobin. Maybe it's the RBC cell membrane. Cell membrane. Again, you wait for 3 months and then you do osmotic fragility test. Osmotic fragility. How do you do it? You see, this is how the peripheral smear of a HS patient looks. Peripheral smear. You see, this is a RBC with central pallor, right? Donut shaped central pallor. In hereditary spherocytosis, because of the proteins on the cell membrane skeleton, cytoskeleton, this donut can't be made, it becomes spherical. Hereditary spirocytosis, right? When it becomes spherical, the central pallor goes. You see this? You see that? That RBC is uniformly dark. There is no central pallor. This is a spherocyte. This is a spherocyte. So that's how the peripheral smear of an HS patient looks, right? And then what do we do? Okay, to diagnose further, I'll come to that. Now, so DCT negative anemia, you have features of hemolysis, splenomegaly is there, membrane problem, hemoglobin problem. Splenomegaly is not there, enzyme problem, inherited but enzyme, G6PD, pyruvate kinase, etc. This is how your workup will go. And there are many more causes of hemolysis in children which are similar to those in adults. We will come to that. Okay. Just some detail about hereditary spherocytosis. I told you on the peripheral smear, you see the RBCs don't have a central pallor. Yeah, they are uniformly stained because they are not donut shaped. They become like a ball. And you can also see this is a nucleated RBCs. I told you immature RBCs coming into the blood. What we do is we dilute the patient's blood. We dilute the patient blood and we dilute the donor blood. You see, this 0.9, okay, percent NaCl is your normal saline. You know, normal saline that you infuse is 0.9%, correct? We dilute the blood. We take multiple tubes. Now, normally what happens is in normal individuals, the RBC is donut shaped. When you put in hypotonic saline, hypotonic, okay, zero point 0.9, less than zero point 0.9. So 0.8, 0.7, 0.6, 0.5, 0.4, 0.3, 0.2, 0.1. Hypotonic saline, you know. So what is going to happen is the saline water is going to enter the RBC and the RBC will start swelling. And after some point, it will burst. Okay. In osmotic fragility test, we make lot of hypotonic tubes and we see in which tube the RBCs have started bursting. Did the RBC start bursting at 0.8%, 0.7, 0.6, 0.5? The more dilute, right? It will take more water. So it takes some time for normal donut shaped RBCs to swell and burst. But in spirocytosis, they're already like a ball. They're already like a ball. So even little bit of water goes in from the hypotonic saline, the RBC is going to break. Yeah. So in osmotic fragility test, you see this is the curve for hereditary spherocytosis, where the lysis started at zero point 0.6 only, 0.7, 0.6, the lysis started. Okay. Whereas in normal RBC, lysis only starts in the later dilutions. Okay. So this is one test that we use for hereditary spherocytosis. So the cells start breaking earlier, even when the saline dilution is not too much. But actually, we don't do this nowadays. What we do is we send the patient's blood for flow cytometry. Flow cytometry. You know what is flow cytometry? There is a dye, EMA. You see this? Eosin 5 malimide dye, this dye. So when we send the patient's blood to the lab, What they do is they will centrifuge and separate out the RBCs. They'll suspend the RBCs in another liquid and they'll put this EMA dye. This EMA dye is a fluorescent dye. It's a fluorescent dye. So this dye will stick to the RBC membrane. It will stick to the RBC membrane on some proteins, like band 3 and all that. Now, what happens in hereditary spherocytosis is this protein is not there. Band 3 protein and other proteins of the cytoskeleton, the cell membrane skeleton, they are not there congenitally. So the dye cannot stick. The dye cannot stick. So what happens is when you do flow cytometry to measure how much dye is sticking to the RBCs, you will see it is less than normal. So we do actually today for diagnosis, what we do is EMA flow cytometry to show that this patient's RBCs are defective, the dye is not sticking, it's very weak compared to the normal RBCs we use as a control where the dye is sticking to majority of RBCs, and this is diagnostic. Of course, ultimately we go on to mutation analysis. So this is, how you look at hemolysis, which is DCT negative in a child. What about an adult? Same approach, peripheral smear. But now you're looking at something else. You remember I told you that most of the acquired problems, in most of the causes of hemolysis in adults are acquired. Common sense, right? Because congenital problems will present in childhood. If they have not presented till adulthood, usually it is an acquired problem. So what are the acquired problems that we're looking for in adults? You need to call your pathologist and tell them, hey, man, I'm suspecting hemolysis in this patient. DCT is negative. Can you tell me if the RBCs are broken? Schistocytes. Schistocytes means broken RBCs. Okay. They will say, yeah, RBCs are broken. When they smear the peripheral smear on a glass, some RBCs will break. You have to ask, no, no, no. Schistocytes should be more than 1% of RBC should be broken. If they are broken, then you will think, oh, maybe this is TTP, which is acquired hemolytic anemia. How will you confirm? You look, see if the platelets have also dropped, because along with the red cells, even the platelets will break. What happens in TTP is fibers are laid down in the blood vessel, and as RBCs and platelets pass through these fibers, they break. So platelets drop, hemoglobin drops, and blood supply gets hampered to the CNS and the kidneys. So the patients will come with neurologic sign symptoms. They'll come with confusion. They may present a stroke. They may come with seizures, right? And how do you diagnose? You send a blood sample to the lab for ADAMTS 13 level. You check the ADAMTS 13 level. Okay. So your peripheral smear showing cystocytes more than 1%. This is what you do. Okay. Now, why am I telling you this as first? Because this, if we delay the diagnosis of this particular hemolytic anemia, if we don't start urgent plasma exchange, the patient will die. On the other hand, if you start urgent plasma exchange, you'll be able to save the patient. What are the other causes whereby RBCs can break? Mechanical heart valves. You know, you've studied and I'm sure you've all seen patients which have a heart valve replacement. They're either biological valves or they're mechanical valves, right? So biological porcine valves or mechanical valves. Now mechanical valves will open and close a bit roughly and that will break the RBCs. So some patients who have heart valve replacement will present with anemia, and you have looked at iron B12 folate, that's okay. And WBC and platelets are okay. So you're not worried of a marrow production problem. And then you notice there is slight icterus. And then you do liver function test and you see indirect hyperbilirubinemia only. SGOT, SGPT is all right. Then you do LDH, then you do haptoglobin, and then you do an echo. Why? Because this heart valve breaking RBCs at a steady level, but it can become worse if there is infective endocarditis. So a person with the artificial heart valve comes with recent onset anemia. You have to tell the cardiologist to rule out infective endocarditis. The infective endocarditis, bacterial colonies, clumps, will not allow the valve to close properly and thus more RBCs will break. So this is the second thing that you will see from peripheral smear. Then sometimes peripheral smear will show what is called as Burr cell or spur cell. This is seen in liver and kidney failure. Okay, what happens essentially is the in the liver and kidney failure, the cholesterol metabolism becomes problematic. Cholesterol metabolism becomes problematic, and our cell membrane has a lot of lipids in it. Has a lot of lipids in it. So there is a balance of different types of lipids, and that balance gets disturbed. So the RBC membrane, instead of remaining smooth, becomes spiky. Spiky, like spurs are there. Burrs are, I'll show you the image, right? So if you see spur cell or burr cells, maybe this hemolytic anemia is acquired because of liver or renal failure. And then every now and then you will get a patient with fever or not even much fever, and your pathologist will say, Are, I'm seeing falciparum. So it's just a malaria parasite growing in the RBC, which breaks the RBCs and causes hemolysis, causes anemia. Okay. What else can you see? You can see septic changes. There are some patients who have high spiking fever, pneumonia, bad pneumonia on ventilator, and there are some bacteria. One of them is, there are some gram negative bacteria. One of them is Clostridium perfringens. So these bacteria, they release some toxins that will damage the RBC membrane and cause hemolysis. How will you know? You will see other features of sepsis on the peripheral smear. So you will see increased granules in the neutrophils, etc., etc. And of course, the patient will be sick, CRP will be high. You will also look for DIC because sepsis can lead to small clots, disseminated intravascular coagulation. In tiny capillaries, you will get tiny clots. And again, in these clots, the RBCs will get trapped and they will break. So, DIC, particular gram negative bacterial infections, can lead to hemolytic anemia. What if the peripheral smear is normal? Well, your direct Coombs test is negative, do the indirect Coombs test. What is indirect Coombs test? Indirect Coombs test will look at antibodies against the RBC, which are floating in the plasma. They are not yet sticking to the RBCs. Okay, they are not yet sticking, they're only floating. They're only floating. Why are they floating? Why are they not sticking to the RBCs? Because these antibodies are not autoimmune. They are not autoimmune. These antibodies were made by the patient not to kill his or her RBCs. What had happened is by chance, your blood bank gave blood which is not correctly cross match, right? And we have all seen this. Patient required blood because there was road traffic accident or bleeding or intra-op during some surgery. Blood was given and there was an error from the blood bank, and say A positive patient got B positive blood. Now, when you put B positive blood, the patient's immunity will make antibodies against the donor RBCs, not against self, against donor RBCs. This is called alloimmune, alloimmune hemolytic anemia. In this condition, you will see immunoglobulins or antibodies floating in the plasma by indirect Coombs test. If this is also negative, then you have to start thinking that RBCs are breaking in the spleen. It's not schistocytes, it's not Burr cell, malaria, sepsis, ICT is also negative. Maybe there is just hypersplenism. You will not believe how many times, we found that actually the patient had cirrhosis, and because of cirrhosis, the spleen was big. And that cirrhosis was missed by ultrasound. Because ultrasound, there can be errors. We can't blame anyone. So we do a CT abdomen to look for cirrhosis, hypersplenism, spleen size. Maybe the RBCs are only breaking because the spleen is big. Or rarely you may be left with this condition called PNH. PNH, paroxysmal nocturnal hemoglobinuria, which is again immune. Okay, it's immune, but there is some damage to the RBC cell membrane. So the complement, system of our immunity breaks down the RBCs, leading to hemolysis, and the hemoglobin comes out in the urine. So there is paroxysmal, intermittent cola-colored urine. These can also have thrombosis, these patients. And eventually, many of them lead to aplastic anemia, bone marrow failure, pancytopenia. So, these are your common causes of DCT negative hemolytic anemia in adults. Of course, there are more. Of course, if you go to a textbook or read a journal, you will find 10 more, causes. Like I said, we are only working on your common practice. Yeah. So this is what, and of course, if all of this is negative, you're going to look for other causes. No doubt. Somebody is, yeah, drawing on the screen. Please avoid that. So this is, children, adult, etc. And now let's come to a couple of cases. Do you want to take 5 minutes break? Okay. So we'll finish. Yeah. The two short cases, nothing great. So patient number one. Okay. This is a real, both of these are real patients, okay? So 46-year-old gentleman came from Jammu and Kashmir 3, 4 years ago. And our hospital had a very strong liver transplant team. So they used to get patients for liver transplant. And so that team referred this patient to me. They said that, he has cirrhosis and they are planning him for a liver transplant. His daughter or sister or somebody is the donor. But their problem was they said, yeah, he's had two admissions for liver failure and one for SBP, but he's come out of it and they want to quickly proceed with a liver transplant. However, his hemoglobin kept on dropping, although he did not have major bleeding. Yeah, 1 year ago he had hematemesis and they had seen esophageal varices and done the banding. But last 1 year there is no major bleeding, no bleeding at all. However, he has recurrent anemia for almost 2, 3 years now, and severe anemia, right? His hemoglobin never comes over 6.57 grams, and they have to give blood almost every 1 to 2 weeks whenever the HB drops below 7 grams. So they said this is very unusual. They don't see this in patients with cirrhosis. Hasn't received any other transfusion. So, excuse me, what exactly is happening? So, well, I took some history of there was no obvious bleeding, there was no weight loss, and on examination, he was a classic, CLD, cachectic, pale. There was some icterus. There were no lymph nodes because I have to look at the hematopoietic system. See, the hematopoietic system consists of the blood, marrow, lymph nodes, liver, spleen. So the examination in hematology is CBC, bone marrow exam, lymph nodes, liver, spleen. Very simple. So that's what we examine. When I saw him, he was not in failure. And of course, the abdomen was distended with ascites. So I couldn't make out whether the liver, whether the spleen was enlarged. Right. So I looked at the blood reports. CBC showed the HB was 7.3. It was normocytic and RDW was also low. So I was not thinking of iron deficiency, occult blood loss. But the WBCs were also slightly low, although there was the differential count was normal. So majority of the WBCs were neutrophils. Now this is important to know, okay? And you will hear about this, more about this in the next class. You see, the cells which the bone marrow makes, in that neutrophils and platelet have the shortest half-life. They have the shortest half-life. So when there is bone marrow problem, production problem, your neutrophil percentage will be low, lymphocytes will be high because lymphocytes have a long half-life. They will survive even when the bone marrow production stops. So when the neutrophil percentage is good, I think that okay, maybe the marrow is working properly. Yeah, platelets are much, much lower, right? Maybe there is a marrow problem. I don't know what is happening. I looked at the liver. Yeah, there was a hyperbilirubinemia, mostly direct. SGOT, SGPT mildly elevated. Albumin was low. Alkaline phosphatase was okay. I looked at the CT scan which they had done. The liver was shrunken with nodularity. The spleen was large and the portal vein was dilated. So that tells me there is portal hypertension, right? So my provisional diagnosis is yeah, maybe liver failure, hypersplenism, and pancytopenia because RBCs, WBCs, platelets. are getting chewed up by the spleen, are getting killed by the spleen. How do I prove that? What do I do? Well, to rule out hemolysis, I did LDH, but you see, the LDH was slightly high. It was not very high, but it was definitely above the upper limit of normal. Creat was also marginally high. You have to do a bone marrow. You have to show that the bone marrow is normal. Okay, that the factory is okay. There's no cancer in it, there's no dysplasia, the factory workers are healthy, right? There is enough iron in the bone marrow. Okay, and because the bone marrow is normal, because the spleen is enlarged, I would think maybe this is hypersplenism. But why does the hemoglobin drop so much? Why? And then I went back and looked at the peripheral smear. You see, I myself went to the lab, I took the peripheral smear, I looked under it, and I found spur cells and burr cells. Okay, and this is what I told you, the cholesterol metabolism gets wonky in liver failure, leading to disturbance of the cell membrane structure. So the cell membrane of the RBCs becomes spicules. So the final diagnosis was liver failure with early hepatorenal syndrome, hypersplenism, spur cell and burr cell anemia. How do you treat this? This is not a primary problem with the RBC. Remember, I told you in acquired causes, most of the problems are not with the RBC. That's with inherited. Acquired problem, there is something external that is affecting the RBC. Yeah. How do you change this? Only liver transplant will help. So, which means the liver transplant for this patient is required not only for liver failure and SBP and portal hypertension, but also because there is hemolytic anemia because of liver failure. Okay, and even that can only get corrected until with a normal liver going in place. Now, patient two. Now, this is important for you. If there is anything that you take away from this talk, it is this patient's story. A middle-aged lady came with fever about, sorry, this is not 10 week, 10 days ago, about 10, 14 days ago. But then last 6, 7 days, there was no fever and she was breathless for one day. Okay. So it's not like fever increasing and community acquired pneumonia. No, the infection seemed to have subsided and now she has become breathless. And she was severely pale, severe anemia. So her GP referred her to me because she was pale. I obviously looked for basic history. Like I said, in hematology, history and examination is very basic. You look for bleeding, you look for site of infection, you do a general system review. GI GU was okay, no weight loss, past history just hypothyroidism. Otherwise she has never had any anemia in the past. Family history also not significant. So when I examined her, she was in distress, she was breathless, she was sitting up, she could not lie down. Yeah, tachycardic, and BP was okay. Respiratory rate was high. She was maintaining saturation. She was very pale. On examination, like I told you, in hematology, you're looking at peripheral smear, blood, lymph node, liver, spleen. So no lymphadenopathy. On RS examination, I did not get any added sounds. So probably the breathlessness was not because of pneumonia. Maybe it was only because of severe anemia, severe sudden anemia, right? And no other organomegaly. Liver, spleen was okay. So I looked at the CBC and hemoglobin was very low. And if you remember last time I told you, it is also the rate of fall which matters. So in chronic blood loss, iron deficiency, patients can come with 3.6 grams hemoglobin completely stable. They will say, Doctor, I'm fine. I was working in my farm until yesterday. Because this drop in hemoglobin has been over months and years. However, in this patient, there was a sudden drop because of hemolysis. Now, what is the cause of hemolysis? MCV. If you remember, I had also told you last time that in autoimmune hemolytic anemia, the RBCs stick to each other, they become a clump, and your cell counter will give an MCV of 137, 140, 150, which is physiologically not possible. It is physiologically not possible for RBCs to be so big. So when you are getting such crazy high MCVs, more than 120 and all that, then it is not megaloblastic anemia. It is multiple RBCs sticking to each other. So MCV gives me a suggestion. Maybe this is autoimmune hemolytic anemia. WBCs are also high. Platelets are also low. Okay. I don't know why this is happening. So peripheral smear, I am seeing the clumping. I am seeing the agglutination. I'm seeing the small. What happens in AIHA is because the antibodies are sticking to the cell surface. Part of the RBC membrane breaks off, and so the RBC gets converted from a donut shape to a spherocyte, like in hereditary spherocytosis. But this is acquired. In AIHA, you will get round, tiny, round, spherical RBCs. Yeah. Now I am seeing NRBCs also on the peripheral smear. Our pathologist has reported because the marrow is trying to create as much hemoglobin as possible. There is clear indirect hyperbilirubinemia. You see, the bilirubin total is 7.8, with direct being only 1.5. Now, LDH is in the thousands. So obviously there is some cell breakage. What do I do next? First of all, arrange for some blood. Okay? Packed red cells. Now remember, this is severe anemia. So whenever hemoglobin goes below 6, 6.5, if you give blood just the way it is, the patient will decompensate, get acute cardiac failure, and get pulmonary edema. Okay, so whenever hemoglobin is less than 6.5, you have to first do some diuresis, right? So I asked for furosemide before each unit of blood, excuse me, about 30 minutes before each unit of blood. I started oxygen, although saturation was okay, and I connected her to a pulse oximeter. My nurse gave one dose of 40 milligram furosemide IV stat, and I called up the blood bank and the lab. I told the lab to do a retic count on the sample that they had. It turned out to be 11%. I asked for a direct Coombs test, which came out to be positive. And I told the blood bank, okay, quickly get me 4 units of PRBC. Hemoglobin is only 3.6. Half an hour later, the blood bank story is going, right? You know, this is going to be autoimmune hemolytic anemia. And so I told them, you know what, you're not going to get a cross match unit. It's not possible. Any unit you try to cross match, you are not going to get. But they said, what should we cross match? We don't even know the patient's original blood. I said, it's okay. You assume O negative. O negative is universal donor. You cross match O negative units. So they cross match the O negative units. And again, after some time, called back that even the O negative units were not compatible. They had 6 units in stock. They've cross matched all 6, and all the units are incompatible at 3 plus 4 plus, right? Not 1 plus 2 plus. I said, don't worry. This is AIHA. This is what is going to happen. Uh, if the DCT report is also 4 plus, give me the least incompatible. So whichever unit is just 2 plus or 3 plus incompatible. And I will sign, I will take the risk. You give it. Okay. And they said, okay. Meanwhile, and as long as the blood came, we also finished off a portable chest x-ray. Now, being a hematology department, we quickly finish off a bone marrow also. Why? Because AIHA, autoimmunity, can be triggered by underlying malignancy. So you have to rule out lymphoma, etc., before you give steroids. Otherwise, the steroids will mask the diagnosis. So I finished bone marrow aspirate biopsy, finished off an ultrasound to look for liver, spleen, etc. Meanwhile, instead of 4, I gave only 2. Because autoimmune hemolytic anemia, we only want to bring the HB to 5 grams. We are not targeting 10. After 2, HB went to 5.4. I did not give any platelets because platelets are more than 10,000 and there was no bleeding, right? Next day, HB had come down from 5.4 to 5.1. I told you, you see, in hemolysis, especially autoimmune, HB will come down very quickly. So I gave just one more blood. By the next day, I got the bone marrow aspirate report. The bone marrow is normal. There's no lymphoma, and the megakaryocytes are normal, which means even the platelet production is normal, which means the bone marrow is making enough platelets. The platelets are coming out in the blood, and even the platelets are being broken by autoimmunity. So not only the RBCs, even the platelets are being broken. Correct? So I also sent an ANA profile, for autoimmune thrombocytopenia, ITP. So AIHA with ITP. This is called as Evans syndrome. Evans syndrome with no underlying cause, no lymphoma. ANA profile came out to be negative. Treatment plan is, well, continue blood transfusion to keep HB above 5 grams. She was young, she did not have a coronary problem, 5 grams was tolerated. Because there is a lot of blood production, you have to give folic acid. And because it's an autoimmune issue, you have to give steroids. So we usually start with high dose steroids, Dex 40 OD for 4 days. Then on the fifth day, we change to prednisolone, 1 milligram per kg. We give full 1 mg per kg for 1 month and then slowly taper over 3 4 months. Okay, now this is very important. In ITP, after 1 month of steroids, we taper very quickly. In 2 weeks, we stop. But in AIHA, we have to taper slowly. And because this is a combination of both, the taper of steroid has to be slow over 3 to 4 months. And it's going to take some time for the steroids to work. It's going to take at least a week for the hemoglobin to, the hemolysis to reduce. If the hemolysis reduces, the hemoglobin will come up to about 7 8 grams without transfusion, right? And we can't continue steroids forever. So we have to use another immunosuppressant. Most commonly, we use azathioprine. It works in about 60 70% of patients. But if it doesn't work, there are other agents and there is rituximab. So this is a patient of Evans syndrome, that is combined AIHA and ITP, no underlying cause, and how we managed her. So thank you so much. This is our team. We have built 17 hematology bone marrow transplant departments in the last 12 years. We work at Bangalore, and in this year also we are going to start 3 4 new departments, a couple of them abroad, one in Africa, one in Sri Lanka and Bangladesh, and hopefully one in Mumbai. I'm sorry, my internet seems to be dropping off. So that was today's talk. I will share the PPT in the group. I hope most of you have done the pre-test, and after this, please finish the post-test. Would you like to ask any questions? We can discuss. So incompatible comes only with positive and negative groups? No, no, no. Any blood group can be incompatible. ICT in case of AIHA, in autoimmune hemolytic anemia, ICT is negative, only DCT is positive. Um, so in DAT, DCT positive patient, delayed hemolytic reaction. See, hemolytic delayed blood transfusion related hemolytic reaction will be ICT positive, not DCT. Okay. Okay. Thank you so much, guys. Feel free to, discuss patients. Yes, incompatible transfusions can aggravate hemolysis. Feel free to call if you would like to discuss any patient, and catch you again next Tuesday. Bye. See you guys. Thanks.